Good afternoon. This is a live recording. My name is Christopher Mallavarapu. I'm a board-certified interventional cardiologist who runs the cardiac cath physician laboratory at Olean General Hospital. The cath lab here was started in 2013 and it's been operational since then. We have probably done about close to almost 4,000 procedures and done many acute heart emergencies. We probably do about 1% of all the heart attacks in New York State, despite it not being a very big town. The purpose of this talk today is to educate the primary care physicians maybe about some general cardiology topics, talk about some of the imaging that's associated with cardiology, and maybe give you some additional pearls and tips, and then do some additional summaries. Just to give you a little background about myself, I was born in South Bend, Indiana, but I grew up in right outside New York City. I went to school in Brooklyn for medical school, and did my residency in Long Island at Stony Brook, and I did my fellowship at the University of Pennsylvania in Philadelphia. I've been practicing for since 1995, and I've been fortunate enough to work for Olean General Hospital and Colada Health since then. So to start, in terms of as a primary care physician, I think there are a lot of things that you can see when you evaluate cardiac patients. I think that the most important thing is when you initially sit down, and I always tell people, and I try to remember this myself, that I always try to sit down when I talk to patients, because when you sit down, the patient automatically feels that you double the amount of time you spent with the patient. The very first thing, obviously, is when you take the history of the patient in terms of their family history. I always make sure they don't have a family history of sudden death. Check for hypertrophic cardiomyopathy and those kinds of syndromes. The stuff like Marfan's disease, arrhythmic deaths are always important. Obviously, family history of premature heart attacks is always important. In terms of other things, as and obviously all the primary care physicians and nurse practitioners know how to take a history of physical. But I think that when you do a physical examination, one of the things that we often don't check is the blood pressure in both arms. The right arm and left arm should be checked, and you want to make sure there's not a significant difference between the arms, because if there is a difference, that could be an early sign of atherosclerosis. In terms of when you further go and examine the patient, we always check for obviously any significant murmurs, aortic murmurs. Diastolic murmurs are always considered ominous and should be investigated. Systolic murmurs going to the carotids, obviously, those are aortic stenosis murmurs. In terms of, we always check for pulses in all the legs, because peripheral vascular disease obviously can be also associated with heart disease. To further go back, when we check for PVD, we also, especially when it comes to men, we always ask if they have any history of erectile dysfunction, because ED can often precede heart disease by about 2 or 3 years, and so that's an important thing to check. Also, especially when it comes to young people, when you look at patients who present with, when you do an EKG, I always tell, whenever you're evaluating an important pearl, when you're evaluating syncope on an EKG, especially when they're young, is to make sure they don't have what's called WPW, Wolff-Parkinson-White, or prolonged QT interval. That's an important feature when you look at 12-lead EKG when you evaluate the syncope. So, in terms of how to work up the cardiac patients, obviously, cardiologists, will do a whole bunch of different tests, but the most important cornerstone of evaluating anybody with symptoms and signs, you always have to go back to Bayesian analysis. So, for example, trying to order a nuclear scan in a patient with chest pain who's very young would not make much sense. You have to probably start with a plain treadmill stress test first, because of the pretest probability in those kind of patients would be very low. In terms of the additional testing that we have in cardiology, I think that most people will start with stress test when it comes to chest pain. If you suspect valvular heart disease, we obviously would do echocardiography to further check it. Also, another important test that we also sometimes have that we don't go to right away is cardiac MRI, because that can also be an important test to further evaluate the structure of the myocardium, structure of the pericardium, and also give you further information if the echo did not help you enough on the valvular heart disease. Obviously, if the stress tests are abnormal, if the nuclear scans are abnormal, sometimes patients will end up in the cardiac cath laboratory. And we often in our lab, believe it or not, we do a lot of angiography, but 90% of our cases are done from the wrist. And it's important to understand the differences. It's an important thing to decrease, potentially decrease bleeding complications, decrease overall complications, and maybe allow for an earlier recovery and an earlier ambulation. In terms of treating ischemic heart disease, I always think that the most important thing is try medical therapy. Stents are very useful for acute heart attacks, but I think that stents should be used when medical therapies fail or when you have an acute MI. So far we've talked about the history and physical. We've talked a little bit about some of the EKG findings that you may want to look for. We briefly touched on why coronary angiography may be useful. I think I'll probably give you two more brief topics to talk about. One is arrhythmias. People who have palpitations. We have an EP service here at Olean General Hospital, and I always tell people in terms of working up arrhythmias, it's an entire broad spectrum of narrow complex arrhythmias, wide complex arrhythmias. We often also will use event monitors to further diagnose these things. Most important thing, obviously, is to check LV function. If the LV function is normal, that may give you a different diagnosis versus the LV function is abnormal. If the LV function is abnormal into the wide complex arrhythmia, that is a much more ominous sign, and those people should be worked up earlier rather than later. And coming back to the most important thing that I think that you could do for your patients is obviously prevention. So if a person, if you never smoked, if you don't have hypertension, if your cholesterol was always stayed normal till the age of 50, then on the average, a U.S. white male will live to be roughly 88, a U.S. white female will be 89. But only 1 in 20 Americans make it to 50 with optimal risk factors. So if you can optimize patients' risk factors, could keep your blood pressures, in the 110s, 120s, keep your LDL less than 70 in those patients with heart disease, or even lower, I think you can reduce cardiovascular event rates. If you have any questions about any of the things any of the topics that I talked about, you can always call me at Olean General Hospital, 716-373-2600. Thank you very much for your attention.